2, 1. Please start, sir. We are live.
Namaste and good evening, everyone. I welcome you all for today's webinar on Recent Cancer Treatment Update 2024. With immense pleasure, I would like to invite Dr. Sunil Kumar Gupta. He is a Principal Director, NHOD, Hematomedical Oncology and Bone Marrow Transplant in Venkateshwar Hospital, Delhi, for the welcome and introductory note. The stage is all yours, sir.
Thank you for such a kind introduction. Very good evening, dear friends. We are meeting again on a recent cancer treatment update focused on basically the lung cancer. Today we have three eminent speakers, those who will give an insight about the real recent changes in lung cancer management. And the important thing is that today we are talking about the biomarker role, the targeted therapies in adenocarcinoma, even in squamous cell carcinoma, where we are, and what is the present situation of biomarker in clinical practice. And for this, I would like to call Dr. Shruti Dogra. She is the Senior Consultant Pathology and Lab Medicine at Venkateshwar Cancer Hospital. She will tell us about the molecular biomarker testing in lung cancer and what is the importance. Dr. Shruti, please.
Good evening, sir. Am I audible to everyone?
Yes, Shruti,
Yes,
you are
sir.
audible.
So good evening, sir. And we are all together here to discuss upon a very recent topic, as you've already introduced, molecular biomarkers in lung cancer.
Yes.
So, and it is a great pleasure to be among the stalwarts of oncology on this platform. I am Dr. Shruti Dogra. Sorry, I'm joining in from my husband's laptop, so that's why the name is coming as Mrityunjay Nautiyal. So please identify me as Dr. Shruti Dogra. And I'm working here as a senior consultant in oncopathology in Department of Lab Medicine and Pathology, Venkateshwar Hospital. So I'll request for the next slide. So we are here to discuss molecular biomarker testing in lung cancer. So I will be discussing everything from testing and diagnostic point of view as I'm a pathologist. Next slide, please. So, and the content will be the lung cancer incidence prevalence in India, biomarker testing in non-small cell lung cancer, evolution of biomarker test, past and current, and where we stand today, and the key takeaways. Next, please. So the burden of lung cancer in India, according to Globacon 2020. So if we see that the number of new cases in 2020, both sexes in all ages, if breast is 13.5%, lip oral cavity in head and neck is 10.3%, cervix uterine 9.4%, and the fourth number is followed by lung, which is amounting for 5.5%. And in new cases, only in males in 2022, if we say, if we can move the slide this side, again, lung cancer is ranking fourth in number. If we see the new cases, incidence, mortality, and prevalence, we see that lung is amounted for ranked number fourth in all malignancies and 5.5%. And death also, it is ranking number fourth with 7.8%. Yes, next slide, please. Yes. So if we see that approximately 50% of patients with advanced non-squamous cell lung carcinoma have got a driver mutation, a targetable mutation, and which has an FDA approved agent or it is on a clinical trial. If we see here that EGFR sensitizing mutations are holding on to 17%. And followed by that, we have the KRAS, which is 25%. Unknown oncogenic driver detected are 31%. Besides for this, we have the ALK 7% and EGFR non-sensitizing in others is 4%. Followed by MET 3%, HER2 2%, ROS1 2%, BRAF, RET again 2%, NTRK1 1%, and PIK3CA 1%, followed by MEK1 1%. Next slide, please. So the importance of biomarkers in testing in non-small cell lung cancer. Where do we stand? And if we are giving a targeted therapy versus a no targeted therapy, what will be the overall survival in non-small cell lung cancer? As we are seeing, which is done graphically over here, that in targeted therapy, the overall survival will be 18.6 months versus no targeted therapy, the survival is 11.4 months. Yes, next, please. So, if we see that routine testing for molecular aberrations as recommended for all adenocarcinomas and in selected cases for squamous non-small cell lung carcinoma. We are seeing the recommendation from ESCO, NCCN, ESMO, and CAP and AMP guidelines. And likewise, if we are concentrating for ASCO and NCCN, so all of these biomarkers have to be evaluated, starting for your EGFR mutations, ALK rearrangements, ROS1, BRAF mutation, MET exon, red gene fusion, NTRK, KRAS, and PDL1. And ASCO and NCCN are giving the recommendation for all of these biomarkers and to target these mutations. Next, please. So, what is the method of tissue testing in these non-small cell lung cancers? So, in tissue testing method, we have the DNA sequencing, NGS, and RT-PCR, and we can detect the insertion, point mutations, and deletions. Also, detecting the aberrations in EGFR, KRAS, BRAF, HER2, MET genes alterations, along with single gene or full NGS panel that we can decide. So if we have the RNA sequencing panel, we detect the fusion abnormalities. And it is RNA sequencing panel is more sensitive than your NGS for ALK and ROS1, RET, and NTRK alteration. IHC and FISH has also got a great role. In FISH, we will detect the ALK and ROS1, and it is highly specialized for these tests, and it can be faster. Now, IHC also is available for ALK, ROS1. Also, there are, finding that IHC is available for EGFR also. It is an easy test, it is fast, but reliability and sensitivity is an issue. Next, please. So now what has been the evolution of these biomarker tests in non-small cell lung cancer? Where do we stand past to current and future? Next. So what is, as a pathologist, in this journey of the patient coming to us to making a preliminary diagnosis and the journey of tissue to analysis and giving a complete targeted personalized therapy to the patient. So firstly, we need to have a tissue and that can be a resection, it can be an excision, it can be a small tissue biopsy. If we have cytology, then cytology can be in the form of so many body fluids. It can be a exfoliative cytology, it can be a cytate fluid. We can have FNAC cytology, and from cytology, we can further make a cell block, which we can process at formalin fixed, paraffin embedded block, and further, then we can do the DNA, RNA, and the protein extraction from these. So all this tissue, the dissected small tissue biopsies, the fluids in cytology, and the liquid biopsies from the blood, these all three can be subjected to further testing, and the assessment methods would be PCR, cancer gene panels, MSI, and your exome sequencing, and your genomic sequencing, targeted mutations, your RT-PCR, RNA sequencer, and proteomics and facts. And all these people are the key personnel who are going to be involved in this tissue journey would be the surgeon, pathologist, and all, even your radiologist, your health professionals, and of course, the patient will be the centrifugal point. Next, please. So we have the biopsy. We have to establish a diagnosis, determine a histological subtype, and then go for the biomarker testing. So the molecular biomarker testing is not the preliminary test. As soon as we receive tissue in the laboratory, firstly, we have to do a histological subtyping, which will be on the basis of your routine hematoxylin eosin staining first, and to determine whether it is a squamous or non-squamous, and whether it is a primary tumor or a metastatic lesion, which is equally suitable, or we have the liquid biopsies are another option. So first, through the routine morphology and through IHC, we have to establish the histomorphological subtyping of lung cancer. After that, then we can go for tests for EGFR, ALK, ROS1, BRAF, V600E, NTRK-RET, MET exon 14 in all non-squamous, non-small cell lung cancer. So we have to use broad NGS testing to detect most mutations using least amount of tissue, because tissue is very important. There is always an issue of tissue for lung biopsy, so tissue is very important. And for squamous subtype, we will consider this testing in young and never or very light smokers, or if the biopsy is showing a mixed histology like that of an adenosquamous. We have to test for PD-L1 expression in all non-small cell lung cancer. Yeah, next slide, please. So what are the stages in non-small cell lung cancer, and what will be the treatment pathway in this? So first we have the diagnosis and treatment selection. So what is the ctDNA? This is the cell-free DNA or the circulating tumor DNA genotype. And what is the role of the circulating tumor DNA type in the stages of non-small cell lung cancer in diagnosis? So your circulating tumor DNA genotyping is recommended for clinical use in very advanced non-small cell lung cancer to guide treatment selection under specific circumstances. So that is the important, that under specific circumstances. So your circulating tumor DNA testing should not or may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer, as well as to monitor prognosis, response to treatment, and progression or relapse of the disease. The circulating tumor DNA has got a very important. Also, with your circulating tumor DNA testing, overcome some major challenges associated with tissue testing, like in cases of minimally invasive carcinomas for patients, allowing for serial biopsy if needed. Also, if your circulating tumor DNA in the bloodstream is compromised of DNA from all other tumor sources in the body and captures both tumor heterogeneity and tumor changes over time. Next, please. So there are similarities and differences if we compare the tumor tissue and liquid biopsy testing for molecular alterations. So what are the, if we compare both the things, so if we see the sample acquisition, if we are going for the routine tissue biopsy, invasive surgical procedure is there to obtain the tumor tissue. But if we compare with liquid biopsy, it is a very simple, non-invasive blood draw. Generally, 10 ml of whole blood is sufficient. Repeat sampling, serial testing is challenging as we are acquiring the tissue through an invasive patient. And patient is at a risk. And the repeat sampling is very easy in case of a liquid biopsy. And if we consider the biology, correlation with the histology and cellular phenotype is possible with tumor tissue. Whereas this direct correlation between the circulating tumor DNA results with histology and cell type is not possible. It is more reflective of the tumor genomic landscape rather than will be no comparison of the histology. Sensitivity of assay, lower tumor cell content acceptable with sensitive techniques, 1 to 10%. Very sensitive methods required as your circulating tumor DNA may compromise less than 0.1% of your cell-free DNA. Analytical standardization. Tumor tissue is done on the routinely well-established protocols, which are validated, and handling procedures are well-established. But your standardization in case of liquid biopsy requires high level of expertise and validation has to be done. So evidence of clinical utility, substantial evidence for initial targeted treatment, selection, and subsequent treatment after the targeted therapy. And in this, as compared to liquid biopsy, less but increasing evidence for initial targeted treatment selection and subsequent treatment. Yeah, next, please. Yeah, one. So, as the number of clinically actionable biomarkers have increased, the ability to evaluate all known molecular alterations in a single test has given NGS a major advantage. So now, earlier what was happening was that the single gene were, targeted and they were being evaluated. So if one or few molecular markers are needed, higher cost and longer turnaround time versus a single gene. So if we are comparing the single gene and NGS, so NGS cost-wise is higher and turnaround time is also higher. But if many molecular markers need to be evaluated, then NGS offers a reduced cost, shorter turnaround time, and lower tissue requirement versus a single gene. And pros of using NGS versus single gene test: detects a broad range of molecular alterations in single sample and may identify new markers that could offer additional treatment options for a patient and provide information to help with development of new and more effective treatment. And cons of using NGS versus single gene test: high complexity of workflow and requires experienced personnel. Advancement in field of NGS are evolving rapidly. Patients and clinical community must receive sufficient education in this area. Next, please. So, techniques used frequently for mutation detection based on, these are the mutation detection techniques which I've already told you. These are the single gene assays, we have the Sanger sequencing, we have the gene panels, allele, RT-PCRs, multiplex ligation, but these days FISH is also recommended for so many others, and we have the NGS, in which we can detect the variant types of SNVs and CNVs. Next, please. So this again is the whole paradigm and the whole, whatever the molecular biomarkers which are recommended by NCCN latest guidelines and by CAP guidelines in a non-small cell lung carcinoma, which it is a busy slide, which I can see that EGFR, which is TKI sensitizing, is comprising of 30 to 40% of our adenocarcinomas, followed by KRAS, 20 to 30%. And then we have the MET exon, which is around 2 to 5 and 3 to 4%. Then ALK fusion, 3 to 7%, and BRAF, 0.5 to 5, followed by ROS1, 2 to 3, then RET, NTRK, 1 to 2%, HER2, roughly 1 to 5%, and encompassing the others, PTEN and PDGFR and PKI3CA. Next, please. Now, if we talk EGFR mutations in lung adenocarcinoma, encompassing roughly about 30% of our lung adenocarcinoma. So, sample types used for EGFR mutation testing, we can have in embedded section, we can have fresh, frozen, or imperfect specimens can be used for RT-PCR or PCR-based assays. And cytology samples are also suitable. We can make cell blocks are preferred over smears. And discordance between EGFR mutation status in primary tumors and corresponding metastatic size is a rare finding through many of the studies. Yes. So now, once we see the NCCN guidelines for non-small cell lung cancer, which is the version 1.2, we see that we consider adding molecular testing for EGFR mutation to be performed of diagnostic biopsy or post-surgical resection sample to ensure that the EGFR mutation results are available for adjuvant treatment decisions for patients, especially with stage 1B to 3A in non-small cell lung cancer. Yeah, next, please. So, advantages of NGS over PCR. That there are studies that have showed that 48.6%, nearly 50% of your EGFR exon 20 mutations identified via NGS are missed by PCR. And one of the 17 most common EGFR exon 20 mutation variants, only 4 can be identified via PCR. So, for giving targeted therapy, NGS is of paramount importance where we can evaluate the EGFR mutations and the molecular alterations. Next, please. So now, if we talk about ALK rearrangements in non-small cell lung cancer, which these ALK rearrangements are amounting to 3 to 7%. EGFR, ALK, and KRAS molecular alterations are mutually exclusive. However, some 2 to 3% of cases of lung adenocarcinoma, they have been described with other molecular alterations too. ALK fusion genes are detected by FISH, IHC, and PCR, RT-PCR. FISH and IHC have high concordance. And the antibodies which we are using in the laboratory are 5A4 and DFF3, which are FDA approved. Next slide, please. So these are some correlations between ALK IHC and ALK FISH in cases studied by both the techniques. So I will like to highlight that ALK we can do, IHC is available and FISH is also there. And false positivity rate is 0.1% with FISH. IHC is less expensive, maybe less specific, but it is widely adopted as a screening technique. Next, please. Now talking about ROS1 rearrangement in non-small cell lung cancer, it amounts to 1 to 2% of cases. And ROS1 rearrangement lung cancer is rare. Assessment of ROS1 protein expression by IHC may be used as a screening tool. And the IHC clone which is being used is D6. Next slide, please. Yeah. So if we see an algorithm which we can practice routinely, we see that non-small cell lung cancer, adenocarcinoma, non-squamous and non-smoker with squamous histology. So if we want to evaluate ROS1, we do a ROS1 IHC, and if it is positive on IHC, then we go for reconfirmation by second method, that is the FISH or molecular assay. And if IHC is negative, then we stop here. In case we are going through the FISH, if it is positive, then again reconfirmation by second method is recommended. And if it's negative, nothing much to be done. Evaluation of EGFR with KRAS is through PCR and NGS, and ALK is through IHC and FISH. Detection of elevated ROS1 protein level by IHC may provide a cost-effective screening prior to confirmatory FISH technique testing. Next, please. We are talking about the KRAS mutations. These are, as already highlighted, these are mutually exclusive with EGFR and ALK mutations. And almost 30% of lung adenocarcinomas after following the EGFR alteration. The most common of these arise in codon 12 and 13 with G12C variant, which is the commonly found for KRAS mutation. Is through multigene NGS panel and BRAF mutations. So BRAF mutations can be targeted with BRAF inhibitors. And in BRAF mutation, V600E mutation is present in more than 50% of cases and comprising 1 to 5% of over. Yes, please.
Dr. Shruti, you have some technical glitch. Dr. Shruti, some technical glitch. Nishant, I think so. There is some technical glitch from Dr. Shruti side.
Okay, sir. We will connecting with him.
Okay.
Sir, ma'am is joining in 5 minutes.
Okay. Nishant, what happened? Nishant? Hello, Ashish? हेलो
सर
निशांत।
उन पे लिंक ब्रोक हो गया है, उनको लिंक रीसेंड करा है, वो कर रही है ज्वाइन।
ओके ओके ओके।
Hello, am I audible? Hello.
Yes,
Yes,
ma'am.
Shruti, you are audible.
Yes, sir. Sir, there have been
Ma'am,
some.
your voice is not clear.
नहीं नहीं, yes
Hello,
yes
Shruti ma'am.
Yes, is it clear now? Actually, no, there has been some technical glitches. So,
yes
is it
yes
okay?
yes
Is it okay
yes
now?
yes yes Shruti, okay.
Yes,
ahead.
yes. Yes, sir. So, we were talking about the MET receptor tyrosine. And
Hello,
for MET
Shruti ma'am,
mutation,
you are not audible.
yeah, just a minute.
Shruti is audible. Shruti, means you are audible.
Right, sir. Sir, so method recommended for MET mutation detection. IHC is not recommended. FISH not recommended. But we have many mutations. And RNA NGS is the most
Hello, Shruti
sensitive.
ma'am, you are not audible.
Not audible. Hello.
Ma'am, you are perfectly audible. Please continue.
Yes, audible.
Yes, yes.
Shruti,
So
yes, you
for
are audible.
yes, yes. So NGS RNA is more sensitive for MET mutation detection. Next slide, please. Next one, please. Hello.
निशांत नेक्स्ट स्लाइड प्लीज।
Next slide, please.
Nishant, move the next slide. Nishant, hello? Nishant, move the
Hello.
next slide. Yes.
Yeah. Okay. So now we have the next one is the NET receptor tyrosine kinase fusion. So majority of these RET fusions can be detected by DNA NGS, but increased sensitivity with RNA NGS. So the point of concern is that there are many like RET tyrosine kinase. RNA NGS is the recommended method for detecting this alteration. Next, please. Next slide, please. Yeah. So as already highlighted, method for RET fusion detection, we have IHC, we have the FISH, we have the DNA NGS and RNA NGS, and majority of RET fusion detected by DNA NGS, but increased sensitivity with RNA NGS. Next slide, please. And now testing for NTRK fusion, we have various options like IHC, RNA, DNA NGS, FISH, and RT-PCR. RNA NGS is the most sensitive for NTRK fusions. Next slide, please. So we have, if we compare IHC, FISH, and NGS for detecting NTRK fusion detection, the recommended and most sensitive method is the NGS as compared to IHC and FISH, although IHC is less costing and turnaround time is much lesser than NGS. Next slide. So HER2 mutations in non-small cell lung cancer. HER2 presents 3 to 5% of these adenocarcinomas, and mostly exon 20 in-frame insertions are detected. HER2 mutations and amplification is detected and identified using an NGS DNA panel. Next slide, please. So this is the treatment paradigm for molecular biomarker, which is positive in advanced non-small cell lung cancer. I will not go into the detail of this. I will leave it to my friends oncologists who can talk about the recommended therapy and the chemotherapy which can be given with these advanced mutation, which is EGFR classical, uncommon type, ALK mutation, ROS1, BRAF, NTRK, RET, MET, and KRAS G12C. Next slide, please. So PD-L1 overexpression in non-small cell lung cancer. PD-L1 antibody clones and IHC platforms and many of the scoring systems are available depending on the platform, which is DACO, Ventana, and DACO according to the antibodies used, and we can have the tumor proportion score. If it is more than 1%, it is positive, and more than 50% to 100 is considered PD-L1 high. Next slide, please. So this is the IHC and the PD-L1 testing, different antibodies which are being used, and the photomicrographs have been captured according to that, giving a scoring system. Next slide, please. So biomarkers for immunotherapy in non-small cell lung cancer is a controversial topic, as PD-L1 is a sole current biomarker able to guide the immunotherapy. If immunotherapy is warranted, then we have to do the PD-L1 testing, and according to that only immunotherapy will be given. And tumor mutational burden, it is a former marker for response, not currently used or recommended. There is a conflicting correlation with survival in the CheckMate studies. MSI and MMR are not used or not relevant in lung cancer. And LAG-3 is possibly related to resistance immunotherapy and is under study for future opinion. Next slide, please. So conclusion, biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing. Multidisciplinary meeting help in better understanding of sample and test requirements. Sample should contain adequate tumor content, which is very important. At least 10% of the tumor cells should be there, which should be viable and which can undergo the further testing. No delay in processing should be there. An ideal TAT should be within 2 weeks. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated time. TAT. Next, please. So as I've already highlighted, so this is the crux of the thing. The oncogenic driver mutations which we are targeting, EGFR mutation through PCR, NGS, BRAF, PCR, NGS, and IHC is also available, though extensive validation is required. KRAS through PCR, NGS, ALK, ROS1, FISH, and NGS recommended. IHC used for screening. RET rearrangements through FISH and NGS, MET through NGS, NTRK, MET through FISH, NGS, and NTRK, IHC is also available. HER2 again for PCR and NGS, and tumor mutational burden through NGS. Next slide, please. Okay. Thank you for a very patient hearing, and despite of some kind of glitches were there. Thank you.
Thank you, Dr. Shruti, for enlightening regarding the biomarker in lung cancer. As you mentioned about that the lung cancer need a multidisciplinary approach, basically as
Right.
radiation oncologists, medical oncologists, surgical oncologists, and chest physicians are important. The pathology is backbone. Today we have a second speaker, Dr. Jyotika Jain, Director and Senior Consultant of Radiation Oncologists at Narayana Super Specialty Hospital, Gurugram. She will tell us about the overview of lung cancer, and I would like to call Dr. Jyotika Jain for his deliberation. Dr. Jyotika Jain, please.
So, am I audible? Good evening.
Yes, yes,
sir.
good.
Thank you very much, sir, and thank you, AstraZeneca, for giving me this opportunity. So, can I share my slides, please?
Yes. Good evening, ma'am.
Good evening, Dr. Shruti. How are you?
Good to
Very
see
well
you.
presented.
हाँ
Very good to be such a lucid presentation. So, thank you.
हाँ जी, हाँ जी, हाँ जी. Good to see you, ma'am.
Thank you. So, I'll start my talk. So we are going to just talk about overview of lung cancer. My work is much easier now because Dr. Shruti has covered many things. So it will be easier for me. Please, next slide, please. So if we talk about the burden of lung cancer, next slide. Lung cancer is one of the fatal malignancy. And if we see a lot of new patients, they are there in each year. Every year, we tend to see almost 70,000 patients. And if we see mortality in lung cancer patients, just next slide, please. Almost 60 to 65% of patients, they die of lung cancer. So it is such a fatal disease. We really have to see what we can do and how exactly we can manage them. Next slide, please. So as I told, new cases, they are quite large. So exactly, if we want to treat any patient, first of all, we should know the exact staging. There are a few changes in the staging in AJCC 7th edition and 8th edition. Earlier, if we see size of the tumor, 5 to 7 centimeters, they were in 2A disease, but now size of 5 to 7, that along with that, if node positive disease is there, they are considered as stage 3. If size of the tumor is more than 7 centimeter and node negative, still it is in stage 3. And second change is in 2, if T2A and B, when it is 3 to 4, then it is 1B, and 4 to 5, it is 2A now. So there are few studies which are saying if tumor is more than 4 centimeters, there is role of adjuvant chemotherapy and adjuvant therapy. If high-risk patients, they are there and size of the tumor is more than 4 centimeter. Next slide, please. So while coming for appropriate staging, we need to see, do various investigations. If any lung patient comes, first of all, they bring with them a CT scan chest, which guide us about how exactly we'll be proceeding further for investigations. Where is the site of lesion, size of lesion? So first of all, that is guided by the CT scan. Wherever, if lesion is central, we proceed with bronchoscopy. And along with that, various other investigations, they are done, PET-CT, EUS, EBUS, mediastinoscopy, and MRI, which helps us in defining the stage of the disease. And if CT, where exactly lesion is located, if it is central, peripheral, or if occurred lymph node metastasis, there we will be discussing in few more slides. Next slide, please. So if CT versus PET-CT for staging in stage 3 lung cancer, this is very important. If we see CT, the sensitivity of CT alone is low, 55%, and specificity is 81%. So if any lymph node which is more than 10 centimeter in short axis, that is a predictor of malignancy. And if we add PET-CT scan, PET to CT, then the sensitivity of lymph node detection, that becomes to the tune of 80 to 90%, and specificity increases from 85 to 95%. Next slide, please. And along with that, N2 disease is very important, because as soon as N2 disease is there, the treatment plan changes from early stage to advanced disease, where modality of the treatment changes. So if any of the factors they are there, we have to suspect N2 occult disease, like size of the tumor, if that is more, like it was seen when size of the tumor is increasing, so like more than 3 centimeter, in those cases, chances of N2 occult disease, which were not detected by imaging, that increases. Secondly, if central versus peripheral tumors, they were there, if any tumor which was central, the probability of occult N2 disease is more. And along with that, if SUV on the PET is more than 4, so we have to remember 3 factors: central tumors, size of the tumor if more than 3 centimeter, and on PET if SUV is more than 4. In all these patients, we should suspect risk of occult N2 disease. Next slide, please. So whenever any mediastinal lymph node staging is done, less invasive procedures, as we all know, and we are doing that routinely, that is EUS and EBUS. and sometimes we require mediastinoscopy. Next slide, please. So whenever, first, if any mediastinal lymph node staging is done, we prefer EUS and EBUS, which are less invasive. But if you have still strong suspicion of any mediastinal lymph nodes which are not picked up on these, then you proceed with mediastinoscopy. Next slide, please. So when do we do invasive mediastinoscopy? So any centrally located tumor when the size is more than 3 centimeter, yes, it is recommended. When extensive infiltration of mediastinum with no extra thoracic disease is there and positive node is there, yes. If bulky N2 on CT, like it is too bulky, then it is not recommended. But if it is discrete, yes, we have to, regardless of PET, we have to do proof of malignancy in that. If normal mediastinum on CT and PET is negative, no need. But if PET is positive, yes, we have to investigate. Next slide, please. So as we discussed mediastinal lymph nodes, if they are negative, positive, and if how is the mass, if bulky, no tissue sampling, lymph nodes, they are bulky. But if lymph nodes, they are not bulky, EUS, EBUS, as we have discussed. And if mediastinal lymph nodes positive, you go with multimodality treatment. Otherwise, same is like over here when lymph nodes, they are negative, PET is negative, as we have discussed. If doubt of mediastinal lymph nodes, they are high, we have to evaluate mediastinum and further plan is decided accordingly. Next slide, please. So we require various modalities, like various stations of lymph nodes, they are accessible by various modalities, like sometimes you require EBUS, EUS, mediastinoscopy, VATS. So wherever different station, what is the CT picture or PET CT picture, whatever is the lymph node status, lymph nodes, whichever lymph nodes they are suspicious, we go ahead with the relevant investigation. Next slide, please. So for staging non-invasive as well as invasive procedures, both are required. And then you have to combine the various modalities to have the final diagnosis of final staging of the lung cancer. Next slide, please. So if we see in earlier days, lung cancer used to be just CA lung. Later on, it became small cell and non-small cell. Slowly, we started having subtypes, squamous, non-squamoid, large cell adenocarcinoma. Then came molecular pathology like EGFR, ALK, ROS, and then PDL1 and tumor mutation burden. So there is a prolonged, like in few years, in 2-3 decades, we are having a lot of change in lung cancer. So what subtype is there? It is relevant for planning and diagnosis as well as treatment. Next slide, please. So it was seen like in this paper was published in NEJM, and it was shown that why advances in management of small cell, non-small cell lung cancer has improved a lot of survival. So patients who were diagnosed prior to 2001, so lung cancer specific survival was to the tune of 26%, but in later part, it became 35%. So main leading cause of that was approval of various targeted agents, therapies in lung cancer treatment. Next slide, please. So if we see in 2006, we were having just few drugs, 2-3 chemo drugs, platinum, bevacizumab, and later in 2011 onwards, we got various targeted agents, and we see in 2021, now we are having a whole list of these, and along with that, various immunotherapeutic agents, they came into picture in 2016, and now we are having whole list of that. So a significant increase in approval of both targeted as well as immunotherapy in non-small cell lung cancer can be seen from this. Next slide, please. So this Dr. Shruti has already discussed. So any molecular targets, as we know, we are having really good molecular targeted agents, which can help us a lot. So whole array of molecular complex is there, but at least 7 to 9, they are really tested in almost, this is recommended and FDA approved drugs. They are there like EGFR, ALK, ROS, BRAF, NRAT, MET, and TRK. So this increases the need for molecular testing. in non-small cell carcinoma, it should be a standard of care. I think there's no doubts about that to anybody now. Next slide, please. So if we see the current guidelines on neoadjuvant and adjuvant chemotherapy, depending on disease stage and finding during surgery. So in early stage, if we say surgery is the standard of care. So in 1A disease, no proven benefit of adjuvant treatment. But in 1B, there is discussions, and now 1B, if any patient is like there should be some discussion regarding adjuvant treatment. But 2B or node positive disease, there is definitely evidence of adjuvant chemotherapy. And in 3A and B, we go ahead with neoadjuvant or adjuvant chemotherapy. N2 disease, if that is there, then radiotherapy is added, and we can go ahead with sequential versus concurrent depending upon other risk factors. Next slide, please. So if we see the findings in surgical specimen, important is in early stage, if all margins, they are negative, and if early stage disease is there, our role, radiation oncologist role, comes when it becomes N2 disease, or if any of the resected margins, they are R1 or R2. And if it is not R2, in those cases, we can go ahead with sequential. But if it is R1, in R2 cases, we have to combine the two if possible. So if we see 1A2, re-resection is preferred, but otherwise RT and chemotherapy plus minus. In 1-2B, you go ahead with re-resection chemotherapy. That is always a standard, but if not possible, CTRT. In R1, we go ahead with sequential. In R2, we go ahead with concurrent. And again, in stage 3A and 3B, if R1 is there, we go sequential, and R2, we go concurrent. And 2 disease onwards, otherwise also, even if all margins, they are negative, we have to add radiation. Next slide, please. So if we see after this surgery, radiation, chemo, in spite of all these things, we see the recurrence in almost 50 to 60% of the patients, either that is local or distant recurrences. So there is need for some more things. Next slide, please. So next slide, please. I'll go ahead with this slide later. So then LACE meta-analysis came, which was showing a pooled analysis of 5 trials, which they evaluated the use of cisplatin-based chemotherapy, and cisplatin doublet with vinorelbine was also used. And they said that chemotherapy led to improvement in overall survival. This we are talking about early stage disease, post-operatively. So there was an absolute benefit of 3.9 to 5.4%, 3.9 and 5.4% at 3 to 5 years. So the role of adjuvant treatment came in early stage disease. This was, I think, in 2016. The previous slide, please. In ESMO guidelines, they also showed that if the tumor size in early stage is more than 4 centimeters and few risk factors or few high risk factors, they are there. If you add adjuvant chemotherapy, there was benefit in those patients also. So that is why the tumor AJCC staging changed. 4 centimeter tumor was changed to higher stage, to stage 2 rather than stage 1. Next slide, please. Next slide, please. So what about neoadjuvant and adjuvant chemotherapy? So this was a meta-analysis which showed really comparable results in neoadjuvant and adjuvant chemotherapy. But during the same period, we had a lot of adjuvant chemotherapy trials which were accepted worldwide. So as such, there is neoadjuvant therapy is also really effective, but adjuvant therapy became more in practice. So if we see the results, they were equivalent in both were having hazards ratio of 0.87 and 0.89. So both therapies there, but adjuvant therapy is more in practice. Next slide, please. Now coming to targeted therapy. So once we had surgery, chemotherapy, radiotherapy, then next we move to targeted therapy. So ADAURA trial came in which patients with early stage disease 1B, 2, 2A, where mutations they were positive, they were started on osimertinib versus placebo. So and it was seen that there was 80% reduction in the risk of disease recurrence or death with osimertinib. So this was these were the results at 3 years. So it is now possible to further improve the survival. So we can see with introduction of EGFR TKI's disease-free survival improved from 44% to 90% at 2 years. So this was evaluated for at 2 years. So there was a significant increase in improvement in disease-free survival with that. Next slide, please. So, and along with that, those patients who were negative, they were put on atezolizumab, where PDL1 was more than 1%. So atezolizumab also showed significant p-value, for which use of adjuvant immunotherapy came into picture. Next slide, please. Now coming to radiation therapy is standard of care for many years. Now we'll talk about something about the newer techniques like intensity modulated radiotherapy. In earlier days, 20 years back, we used to use parallel opposed fields where whole of the structures, they used to come in the field. But now with newer techniques, you can just shape the beam and very less dose goes to the adjoining structures. So while treating lung cancer, a lot of problems with three structures will say heart, lung, and esophagus. So all these things, you can decrease the complication, and local control can be improved with the help of newer techniques like IMRT, IJRT. Next slide, please. We have another technique like SBRT, stereotactic body radiotherapy, where you give very high dose to the smaller lesions with the very few number of fractions, like doses given in 1 to 5 fractions. They are suitable for early stage disease, where you can, when tumors, they are less than 5 centimeter, in 5 to 10 days, patient completes the treatment, and it is as good as surgery if patient is suitable for that. And along with that, you have various other newer techniques also. Next slide, please. Like 4D CT or image guidance, and you can do respiratory motion management, in which you can just see a particular phase of respiration in which you treat the patient, so that margins around the tumor that decrease quite a lot. So you can give very high dose with high precision without giving much margins, and you can cure the patient. There is concept of adaptive RT also, when the lesion is too big and it has shrunken and normal tissue comes into the picture. As tumor shrinks and you have to replan sometimes, this is called adaptive RT. Next slide, please. Now, so there was an RTOG trial 0617, which states that was there any use of further dose escalation from 60 to 74 gray, and they used cetuximab plus minus was used in locally advanced 3A, 3B non-small cell lung cancer, but it was seen it was of no use. It was not of much benefit, neither cetuximab nor dose escalation in these patients. Next slide, please. So now, if we go ahead again, chemotherapy with or without radiotherapy is standard of care after complete resection. But if we have adjuvant treatment, we have to see, and we have to see combined, we have to just sit with multidisciplinary board. Like if any patient is not suitable for one particular thing, we can go ahead with other, like sequential can be done if you cannot combine. So there is a role of multidisciplinary tumor board in that. Next slide, please. Now coming to immunotherapy, again, checkpoint inhibitors, they are moving again after a PACIFIC trial, which was a double-blind placebo-controlled trial, in which durvalumab was used in all stage 3 patients where we have given already CTRT. So there was a clear benefit in these patients. Next patient, next slide, please. So it was seen, previous slide, please. So it was seen that when we add initially, when historically, if we use stage 3 and 2 disease, we are giving CTRT in those patients, 5-year survival used to be to the tune of 15 to 25%. But adjuvant durvalumab helped and increased the overall survival to the tune of 42.9%. That is a clear benefit. So now this has become a standard of care. Next slide, please. So basically targeted therapy as well as immunotherapy, they are emerging and they are having standard role. Next slide, please. So targeted therapy, if we see, they are basically chemotherapy, with chemotherapy, median progression-free survival used to be to the tune of 5 to 7%. But with TKIs, we can have survival of 18.9 months, and with ALK inhibitors, it came really good, 34.8 months. So there is definitely a role of targeted therapies in improving the outcome in lung cancer. Next slide, please. So other than that, various other genetic alterations, they are having newer drugs like crizotinib and large, like 4-5 new drugs they are coming. So newer agents, they are being identified, which will be helping us increasing the survival in these subset of patients. Next slide, please. So if we see survival outcomes of with targeted therapy, earlier it used to be with chemotherapy 4 months, 8 months, 6 months. But when we have EGFR, ALK, ROS inhibitors, just see we are having this survival 39 months. So now it is like that. So whole battery of newer agents with recent advances, survival rates, they are improving compared to chemotherapy. There's no doubt. So now we are somewhere in with different mutations, we are having 44 months, 39, 35. Next slide, please. So now coming to immunotherapy, immune checkpoint inhibitors, we use, next slide, please. So if we see, we are using immune checkpoint inhibitors to alter our own immune system to fight cancer. So from 2015 to 21, we are having a large number of things, although pembrolizumab, which is being used most frequently, we are having atezolizumab and nivolumab, ipilimumab. So all these approved ICI immunomodulators, they are there, which are really helping in lung cancer. Next slide, please. So survival with immune checkpoint inhibitors, again, if any of them, they are not having mutations like EGFR, ALK, ROS, and where PD-L1 based therapies they are given. Again, we see earlier it used to be 4, 5 months, 8 months, and now we are having 22 months, 19, 17, 30 months. So that is a blessing. Next slide, please. So we know that checkpoint inhibitors, they have improved survival in advanced lung cancer. Next slide. Even in 4th stage, they are showing 32% patients, they are alive at 5 years with the use of immunotherapy with metastatic non-small cell lung cancer. Next slide, please. So checkpoint, multiple ongoing trials, they are there in the adjuvant setting with for immunotherapy. I think in some more time we'll get results of those. Next slide, please. And like there is antibody drug conjugates, which are used sometimes in breast studies. They are going on for non-small cell lung cancer. Results we'll be getting in some more time. Next slide, please. So CAR T cell therapy is another way which is very popular nowadays, where your own T cells, they are modified and re-injected to fight against cancer. Studies are also going on for that. Next slide, please. So the management landscape is fast changing in NCCN guidelines. Newer therapies have huge potential to improve survival, especially when detected in early stage. Overall survival has improved across various subtypes with molecular alterations. And it is an easy therapy, ease of oral pill over infusion in case of targeted therapy is an added advantage. And pulmonologists will be playing a huge role in early diagnosis, because initially patients, most of the time they present to them, and it is crucial to involve them in non-small cell lung tumor boards. Next slide, please. Thank you very much.
Thank you, Dr. Jyotika, for such an excellent overview of lung cancer. For third talk, I would like to call my colleague, my friend, Dr. Sumit Goyal. He is a Associate Director in Medical Oncology at Rajiv Gandhi Cancer Institute. We learn so many things regarding the biomarkers. We learn about the new targets, but how we will decode is very, very important. And for decoding of EGFR mutations positive patient, which generation of targeted therapy is the standard of care in 2024? Dr. Sumit Goyal will enlighten us, and I would like to call Dr. Sumit Goyal for his talk, which is session sponsored by the AstraZeneca.
So good evening, sir. Thank you very much for the introduction, sir. So let me try to share my screen, sir. Just one moment, sir. I hope my slides are visible and I am audible, sir.
Yes, sir.
Yes,
Okay.
yes, Sumit, you are audible.
Thank you, sir, for giving me this opportunity today, and thank you, Team Astra, for this wonderful platform to interact. So today my topic is decoding treatment options for EGFR mutated non-small cell lung cancer. So I'll be briefly talking about the evidence that we have and where do we stand as the treatment paradigm is concerned. So this slide has already been discussed. So worldwide data of the cancers. So lung cancer is the most common cancer. Again, both in terms of incidence and mortality. So in both genders combined, the lung cancer is the second most commonly diagnosed cancer. That is about 11.4% of the total cases. But what is important is it is a leading cause of cancer death. About 18% of the total death of cancer which happen is because of the lung cancer. So again, it is very important to sequence the treatment. So with newer advances in the diagnosis and our understanding of the molecular pathways, the survival is clearly improving. As shown by the previous speakers, we have so many molecular targets, both in the adjuvant setting and in the metastatic setting. So for adequate responses, the parameters which determine the choice of first-line therapy, they are multiple. It depends on so many factors. So the important one is the progression-free survival. And the parameters that we look for is, obviously, we look for overall survival. But again, the quality of life is equally important. Sometimes we want rapid responses. The response rate is important. So again, we want to know whether there are brain mets or not. And whenever we are looking at the responses, definitely we want to assess for quality of life and safety and toxicity also. So again, we know in the metastatic setting at some point of time, the disease will progress and we need to know about the next line options also. So in EGFR mutated cancer, the drug which impacted the most, which has given the most impact is osimertinib. So osimertinib we know is third generation TKI, but if we look at the data, if we look at the PFS curves from all the studies as shown in this chart, so first generation TKIs, gefitinib and erlotinib, IPAS and optimal. So the PFS was about 9.5 to 13.1 months, which increased with the second gen TKIs, and in with third generation TKI, that is osimertinib, the benefit was unprecedented. It was about 18.9 months, which was not heard in before. So in the previous studies also, if we see, so the progression-free survival, the advantage was there, but the delta was not great. And there were studies which had excluded brain mets, like the Archer 1050, where they had excluded all those who had brain metastasis at the presentation, but the Flora and Lux Lung, they had stable brain mets, and the number was considerable. But if we look at this chart carefully, we can see that in the Flora, as soon as the treatment was started, there was separation of the curves, meaning there was benefit uh, just at the start of the treatment. Again, we should not be doing the cross trial comparison that we know, but still the advantage was there with the Flora, not only the longest, but started at the earliest also. So looking at the response rates, again, the responses were there, but osimertinib had shown the highest overall response rates, which was to the tune of 80%, which is like we don't even see sometimes with the chemotherapy also. And the duration of response again was very good. It was 17.2 months versus 8.5 months in the comparator arm, which is just a double. So if we look at the final OS analysis of the FLORA study, so it had median OS of 38.6 months, close to 3 years. So that was the median OS, and hazard ratio of 0.7, clearly favoring the osimertinib. So what's important is in the two curves, we can see a considerable number of patients, like 54%, 10% more patients are alive at 3 years as compared to the first and second generation TKIs. And in the other studies, we know the PFS advantage was there and the OS advantage was there with osimertinib. So was this advantage there in other studies also? So this advantage in LUX-Lung 7, Archer 1050, we look at two other studies where the PFS advantage was there. Afatinib, it failed to show any OS improvement. And again, Archer 1050, so there was statistical glitch, I will say, because it was a hierarchical analysis. So it was designed in such a way, if there was PFS advantage, then they will go for overall response advantage. If there was overall response advantage, then they will look for OS advantage. So since this study did not show improvement in overall response rate, so technically the OS advantage was not there. The test was not done. So the same thing here, as reported by the Canadians, because of the hierarchical design, the OS advantage was not there in Archer 1050. So this is quite interesting and important. If we see about 30% of the patients, they were still receiving osimertinib at 3 years, which was about 3 times more than that of the comparator arm. So again, so lung cancer, whenever we talk about the brain mets also. At presentation, we need to screen these patients for brain mets. And so is the result different for those who present with brain mets? And how does it fare in those patients who have CNS metastasis? So if we know the patients, they have known or treated CNS metastasis as compared to those without CNS metastasis, the hazard ratio was almost the same. Means it was equally efficacious because we know osimertinib, it crosses the blood-brain barrier and is quite effective there. However, if we look at the median PFS, it was low as compared to those without the brain mets, 15.2 months versus 9.6 as compared to 19.1 months in those without brain mets at presentation as compared to 10.9 months in those in the comparator arm. And again, the CNS progression events occurred in 6% of those patients receiving osimertinib, while it was there in almost 2.5 times more in those who were on the comparator arm. So if we look at the intracranial PFS, so the advantage was there, and the hazard ratio was 0.48, favoring the osimertinib arm. So PFS for CNS mets was also in favor of osimertinib. So again, this is the study summarizing the CNS response to first-line osimertinib in patients who have EGFR mutation positive in the advanced lung cancer setting. So if we look at the FLORA study, the intracranial response the CNS response was not assessed in those patients in the LUX-Lung study, and the clinical benefit was observed with afatinib but not with gefitinib. And CNS clinical benefit was observed with osimertinib, but as compared to the comparator arm. And in the Archer study, we know the brain met patients were excluded. So osimertinib is effective in those patients with brain mets also. Whenever we talk about safety, with efficacy, we talk about safety. So if we look here, last 3 lines, the dacotinib, the grade 3 and 4 side effects were reported in 63% of the patients, which is like every 1 in 3 patients getting a serious side effect. And with afatinib, again, 31% of the patients were having grade 3 or 4 side effects. However, it was the least. Hello? Hello, it was the least with the osimertinib. And if we talk about the side effects,
रोटी नहीं खाऊंगा, दवा दवा पड़ जाएगा।
hello. So if we look at the side effects profile as compared to the other studies, as compared to the flora, so the skin paronychia, diarrhea, and stomatitis, it was much less, just 1 or 2%, as compared to the other afatinib, dacotinib. The skin toxicity quite considerable, 9% and 14%, which was quite high. So again, so the reduction in the doses, it was, if we look at the lung studies, 41.9% of the patients required dose reduction, whereas almost 70% of the patients required dose reduction in the dacometinib group. But if we look at the flora in the osimertinib study, just it was as good as that of comparator study, 5% versus 4%. Very minimal patients require dose reductions as compared to the other two studies. So again, quality of life, if we look at the charts, definitely in Archer, the benefit was not there. In Flora, the global quality was maintained. So why it is important to start the best treatment at the earliest? There are a number of reasons. Osimertinib being the most effective, we need to start it at the upfront as the upfront strategy. There are a number of reasons. One, it has efficacy. Second, we know it not only works in the brain mets, but also helps in reducing the brain events subsequently. And also the most important thing of all, we know as the disease progresses, the second line to third line, only 1/3 of the patients, they will be eligible to receive EGFR TKI in the second line, which is the most important factor. So again, we don't know if we start with the first or second generation TKI upfront, then we can use osimertinib in second line only in those patients who develop T790M mutation. And it is very difficult as of now to predict who will develop this mutation. So again, access to second line therapy, it is a challenge. For a number of reasons, patients do not go on to get second line therapy. So across trials, we see, so approximately 1/3 of patients will not have access to second line treatment. So which is a second important factor for considering the most effective treatment upfront. So again, that was the study's design. We know in clinical trials, the patients that are taken, they are very fit. They are PS0 and 1. So are they different in the real world? Are there differences in the real world if you look at the real world scenario? So we have data. So again, we do not know, as I said earlier, we do not know how to predict who will go on to develop T790M. So the sequencing is important. And the factors that we cannot control in sequences, we cannot control the toxicity, we cannot predict who will get T790M. Again, we cannot predict the sites of progression and the other morbidities. And also we cannot control what determines a patient's choice. So if we look at the real world data, so real world, we have FLOWER study, which was the real world data. It was a prospective study done in Italy. So 9 centers from Italy. So again, if we looked at here, it looks quite realistic for what we practice. In this study, about 30% of the patients, they had brain mets at the baseline. Whereas in clinical studies, the numbers were much less. Again, PS more than 2, 12.7% of the patients, they had PS more than 2. So time to treatment, coming to the results, time to treatment discontinuation, about it was 25.3 months in the real world. And again, we know if the patients have symptomatic disease of brain mets, their PFS tend to fall. So which again was 18.8 months and 21.4 months, again consistent with what we see in the clinical trial scenario. So again, this clinical safety. So there were no new safety signals, and the VTE was reported, but it was again matched as according to age and PS. So in the real world, this study from Italy showed that yes, it is comparable to the trial data. Then the second study, which was from Japan, the OCFACT, here again, 16% of the patients, they were PS2. And again, 31% of the patients, they had brain mets at baseline, which is like 1/3 of the patients they had. So again, if we look at the median PFS, the PFS in this study was 20.5 months, again, which was comparable to that of the in the clinical trial setting. And the median time to tumor failure was 19.1 months. So safety here in Japanese population, they reported more incidents uh, of pneumonitis, which we do not know the real factors why it was so, whether there were like ethnic differences or how the people in different geographic areas react to this thing. Second, the real world experience, it comes from Mykonos. Mykonos was again global observational study done across Japan, Germany, and China. Again, a considerable number of patients, they were elderly. The median age of 70 was there. PS of 2 in 15% of the patients. Brain mets again in 1/3 of the patients. So if we look at the real world time to next treatment or death, it was 17.9 months, uh, which was there as compared to those in so which again matched those of the trial setting. So again, from the clinical trial setting to the real world data, so coming to the guidelines. So guidelines very clearly. So NCCN, if you look at the NCCN, as first line, the preferred therapy, it is osimertinib, which should be used. It is category 1. Though we can use other therapies also, though other also are category 1, but the preferred one is osimertinib. Why so? Because of the reasons that we discussed above. One, we cannot predict the efficacy. We cannot predict the development of T790M in subsequent lines. Third, we do not know whether the patient will access to the treatment in the next line of treatment. So this is the ASCO guidelines. Again, if the patient is L858R or exon 19 deletion, so the osimertinib therapy is the monotherapy is the strongest evidence exists for that, and it's a first line recommendation. So summarizing, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival, which no other TKI has shown till date. The median OS benefit of greater than 3 years. It sets a new benchmark for osimertinib and provides a window of opportunity. The FLORA is the first time an EGFR TKI where PFS translated into OS benefit. At 3 years, about 30% of the patients were alive and were still taking the treatment. So it is and osimertinib is the only drug which crosses the blood-brain barrier and is helpful for symptomatic patients also. And it is the only drug which works for T790M mutation, which other TKIs do not work. So it is, again, from the studies, we know that the dose reductions were there in only 5% of the patient, which was as good as those of comparative arm. So it has the safest and the least toxic drug amongst all. So these data confirm that osimertinib as a first-line standard of care in metastatic EGFR mutated patients as of today. So it is the most effective drug, and with our experience and our learning curve, we find it like it is quite easy drug to use and manage in general. With this, I'll stop and I'll hand you back to sir.
Thank you, Dr. Sumit, for decoding the EGFR mutation treatment option. And now this is not the panel discussion. This is basically a three-talk discussion and refreshing our mind again by this case discussion in a metastatic lung cancer patient, where we are with the presentation of scientific program. I'm sharing my slide. And this is again a session sponsored by the AstraZeneca. So this is a a metastatic CA lung patient, those who are EGFR mutation positive. I just want to discuss and call my expertise, Dr. Deepika Chauhan, Senior Consultant of Radiation Oncology and Unit Head at Venkateshwar Hospital, Dr. Roshan Sharoop from Interventional Radiology side, and my other speaker and colleagues, those who are attending this scientific program. So just see, this is a 54-year-old male, former smoker, smoker for 20 years, and there is a comorbid condition of diabetes mellitus, PS0, presentation with basically suffering from pleuritic chest pain, shortness of breath over the past 1 month. And just see, Dr. Roshan, CT scan is showing a mass in the pulmonary side of the left side. The size is 4.2 is to 3.7, but the abdomen CT again shows a adrenal mets. Dr. Roshan.
Sir, good evening, sir.
Good evening, Dr. Roshan. Would you like to go for a CT guided biopsy or a bronchoscopy in this case for a tissue diagnosis? My first question is this. And second question is, would you like to take a FNAC from the adrenal glands to reconfirm whether this is a metastatic disease or adenoma of the adrenal gland? Dr.
Okay.
Roshan.
Thank you, sir, for the questions. First of all, I will come to the lung biopsy. As we
Yes.
can see, it's a centralized mass.
Yes.
So it's better to go for bronchoscopy guided biopsy first
Yes.
to confirm the diagnosis.
Yes.
And the second question about adrenal lesion, as we know, adrenal lesion is very common in CA lung cases.
Yes.
Adrenal metastasis is very common. So in this case, I think we don't have to prove again by doing any intervention in the adrenal gland to confirm that it's a metastatic case.
Okay. Dr. Deepika, my question to you is, suppose there is a adenoma of this adrenal gland, the treatment will change. Would you like to go for a FNAC to confirm this, or on the radiological basis, would you like to go for a stage 4 treatment?
Good evening, sir.
Good evening.
Yes, sir. So I would like to perform FNAC if it is feasible. Otherwise, radiological evidence, if my radiologist is sure enough, is confident enough to treat it as adenoma, to tell it that it is metastasis, then I'll go ahead with that also.
Okay. Would you like to add any other investigation to check the stage again and confirm radiologically?
So PET CT would be of benefit.
Dr. Roshan, can you
Sir,
highlight?
I'd like to add on, if you are suspecting adrenal adenoma,
Yes.
we can go for CCT.
Yes.
Look for the
CCT we
acute.
have. CCT we have.
No, to confirm not in this case, in general, I am saying.
Yes.
If you are suspecting any adrenal adenoma, we can go for CCT to confirm the HU value.
Yes.
So if it's a fat-containing lesion, that can be
Yes.
confirmed in CCT.
Okay. Dr. Jyotika, majority of time, we always prefer a PET CT scan. Would you like to treat this patient on the basis of CT scan only?
No, sir. I would like to have histopathological confirmation if it is possible. Otherwise, we can go ahead with PET CT, and if two modalities they are confirming, then perhaps if FNAC or biopsy is not possible.
Okay.
Because
Means
whole of the
actually,
treatment will change.
my question is very clear. Suppose sometime there is an adenoma only, benign disease, and there is a disease only in the chest, the treatment will be changed.
Yes, and this is single side lesion. So
Single
it
side
can be
only.
adenoma.
No other side metastatic disease.
Single side in the sense it is not bilateral. So metastasis,
Yes.
and it is single side, so it can be adenoma. How do we know? So we'll have to either confirm, or we have two modalities to confirm.
Okay.
So we can add PET CT, and if FNAC is not possible, then it is a big lesion. Perhaps FNAC will be feasible from this lesion.
Dr. Roshan.
Ma'am,
Your
FNAC is
opinion,
feasible, but if the lesion is not metabolically active and we are suspecting that it's a case of adenoma in CT also, then I
Yes.
don't think we have to intervene the lesion.
No,
Okay.
but the thing is, how yes, if two modalities they say it is not metastasis, Still, that is a possibility. If you are labeling that as metastasis, definitely we need some histopathological proof.
Because in this
lesion.
case, I think it's the NCCT abdomen images showing the adrenal lesion. So
Okay.
in CCT abdomen, the lesion will be heterogeneous with some kind of enhancement if it's metastatic.
Okay.
And if it's a case of adenoma, we will not see any significant enhancement in the lesion in the non-contrast and the followed by the contrast images.
Okay. Dr. Roshan, any role of a MRI to see the adrenal glands?
Sir, MRI is we can go in phase in phase and out phase images.
Yes.
We can go for in phase and out phase images to see for the fat containing status of the lesion.
Okay.
In phase and
Okay.
opposite phase images.
Okay. Okay. So now this patient is having a bronchoscopic biopsy which is suggestive of adenocarcinoma, and diagnosis radiologically we believe that clinically stage 4 because of the adrenal mets, histopathology adenocarcinoma, and Dr. Shruti mentioned about the biomarkers, and this patient is having a driver mutation, EGFR mutation, L8858R positive. Dr. Deepika, you listen about the biomarkers, the Dr. Jyotika Jain's talk as well as Dr. Sumit talks. What is your choice? First generation TKI, second generation TKI, or third generation TKI, even in stage 4? Or
Yes, sir. Yes, sir. Both the speakers have given a enlightened speech. It was wonderful to hear them. And what I could gather is whenever the TKIs should be the first generation.
Okay, okay. First generation, because the drug is cheap, but if you see the 2024 guidelines, they mention about third generation TKI
Osimertinib.
because of the blood-brain barrier crosses as well as T790 mutations covered by this drug, and this drug is now available with the PEP support. So this is the answer. Dr. Jyotika, I think so
Yes,
you are
sir.
concur with me.
So we'll go ahead with third generation TKI, osimertinib. That is the drug.
So this is the recommendation, and basically you can have a category 1 recommendations, but preferred category 1 is osimertinib as a preferred first line treatment in stage 4. So
Right.
Deepika and Jyotika, what are the consideration when you are choosing the first line treatment? Every doctor feel that efficacy, safety, quality of life, overall survival. And Dr. Sumit Goel mentioned about by Flora trial that this matches the osimertinib drug as a first line. Any comment from your side? Once Dr. Sumit has given the lecture, what is your opinion about the evidence and your preference on the basis of this efficacy, safety, and quality of life and overall survival?
So, sir, if the metastasis, the brain metastasis are not symptomatic, they are asymptomatic. So,
Yes.
since osimertinib is showing a good overall response rate, it is
Yes.
crossing the blood-brain barrier. So, we
Yes.
can go ahead with osimertinib. But in case the brain metastasis, if it is infratentorial metastasis without symptoms, or if it is a symptomatic brain met, then we have to add the local therapy, either the
Okay.
SRS or SPRT.
Okay. Dr. Jyotika? Dr.
Yes, sir. So basically, whenever any metastatic disease is there, as various trials, they have shown benefit of osimertinib over other TKIs, first and second
Yes.
generation. So basically, that will be the preferred choice with very low toxicity, and overall disease control is there with TKIs. If we are talking about occult metastasis, first we have to see asymptomatic metastasis in mutation positive, they will be responding. But if any symptomatic lesions they are there, then definitely we have to treat them.
Any comment from any person who want to give their opinion regarding this? Anybody can take a question and give an answer, their experience and their clinical practice experience. Will type of mutation change your choice of TKI? if you see, Dr. Sumit clearly mentioned about the FLORA trial, the efficacy of ofacitinib, highest overall response rate, median duration of treatment. My question is, how important is overall survival to pick up EGFR in your clinical practice in stage 4? Means ositinib shows a 3-year, 28% patient continue on this treatment, 8.6-month benefit seen, and overall survival is more than 3 years. So I'm not going in detail of this because Dr. Sumit has already discussed about these slides. But the question is that while choosing TKI, can you ignore risk of developing CNS mets in your advanced lung cancer patient? But this patient is having only oligomets. Considering EGFR positive non-small cell lung cancer, 25% patient present with brain mets at baseline, and in due course of a time, 50% patient. Do you routinely do brain MRI for all stage patients, even if no symptomatic or no CNS complaint? Dr. Deepika.
Yes, sir. So for locally advanced stages, like you said in your, there are chances to the tune of 25% that
Yes,
brain mets
yes,
can be there, so which is
yes.
a very significant number. So for locally advanced brain metastasis, MRI should be advised, whether
Okay.
patient is symptomatic or not symptomatic. Overall in lung cancer it is 10%, so probably we can avoid it in early stage of cancer, but in locally advanced it should be done.
Dr. Jyotika, my straightforward question to you. Stage 4 cancer, even symptomatic or asymptomatic, would you like to go for MRI?
Yes, sir, definitely. Definitely in all patients of advanced disease, we have to get a baseline MRI that will act as baseline. And if we can get asymptomatic metastasis also, perhaps in those cases, if somebody is going to be started on first or second line TKI, perhaps third line will be again a better option for all of them.
Dr. Roshan, your comments on lung cancer, if patient who is having an adrenal mets, would you like to see in radiologically the brain mets and in stage 4 patients?
Sure, sir. In any stage 4 patients, as ma'am told and Dr. Deepika told, we should go for a CMRI of the brain.
Yes.
To stage the disease and also go for as a baseline scan. If the disease is there, it will stage the disease, and if it's not there as a baseline scan, in further scenario, we can go ahead to compare the previous MRI with the current after chemo, or if patient presented with any kind of symptoms later on, so that we can evaluate whether it was previously there or it's a new development. So it should be done.
So this is a clear message. Whenever there is a patient who is having a advanced stage lung cancer, clinically stage 4, must have a baseline brain MRI to rule out asymptomatic versus symptomatic lung mets. So these are the trial already discussed by Dr. Sumit. I am not going in detail of this because this third generation TKI crosses the blood-brain barrier and showing the response even in brain mets patient. Hypothetical scenario, which is Dr. Jyotika clearly mentioned about checkpoint inhibitors. Would PD-L1 positive favor in the starting of checkpoint inhibitors role? Anybody can take, but I'm just giving an example that tumor, those who are driver mutation positive, they are not responding to checkpoint inhibitor so good, which is commonly seen if the CPS score is more than 1 and the driver mutation is not seen, then the checkpoint inhibitors shows response. Even in second line chemotherapy or chemotherapy plus IO is preferred over the monotherapy. How important is safety of any drug is important in our clinical practice. Dr. Deepika, means as a radiation oncologist, suppose patient is getting radiotherapy, how much you are comfortable with the TKI with radiotherapy in your clinical practice if there is a brain match?
So basically,
would you like to
there is-
stop or would you like to continue?
So I would like to stop, but then when I was referring the literature, so in that many phase 2 trials have come up in which they are combining radiation therapy with osimertinib also. Of
Yes.
course, with a little lower dose, but there are phase 2 randomized also. So probably we are waiting. Maybe once we'll have phase 3 data, we'll be more confident to give it, to prescribe it.
Dr. Jyotika, suppose patient is on osimertinib, asymptomatic, but suddenly symptomatic. You want to give the palliative cranial artery. Would you like to stop the Tagrisso or not?
Definitely, sir. We at present till now, data is not there to support both of them together, and more or less we are giving most of the patients either as SRS or SBRT, fractionated radiation, or gold rain. In those cases, we are giving hypofractionated radiation. So along with the radiation and high dose radiation and TKIs, we don't combine. We don't combine them.
As this is the data presented by Dr. Sumit, the toxicity on Lux 7, Arcal 105, Flora, just see toxicity is much less with the osimertinib 4% and 5% respectively as compared to 52% versus 66%. So does quality of life matter in advanced lung cancer once we are treating? Suppose Jyotika patient is having a brain mets. There are two questions. Asymptomatic brain mets versus symptomatic. Would you like to treat the asymptomatic patient with multiple brain mets?
So the thing is, if we are having brain only metastatic site,
yes,
so I would like to treat them. If the patient is having all widespread metastatic disease with brain as one of the site and patient is asymptomatic, we can wait and watch. So there is a difference. If brain only site of metastasis is there, we'll definitely treat them. If we are having multiple metastases everywhere and brain is one of the site and patient is asymptomatic, we can wait and watch.
Okay. Dr. Deepika, your expert opinion.
So that's what actually it depends. So whatever I have seen, whenever it is an asymptomatic brain mets, we can go ahead with the TKI. But suppose there are multiple brain mets and they are more than size is more than 2 centimeter. The location is infratentorial. Then probably I would be more comfortable with adding local therapy, radiation therapy. Because eventually they will become symptomatic and we do not know the time when that asymptomatic thing will turn into symptoms, and whenever there is brain metastasis, whenever it is symptomatic, it is an emergency. So this is very important to properly review all the points and then take a decision.
Okay. This is the sequencing again discussed by Dr. Sumit Goel in detail, that the osimertinib is having a 47% crossover in the trial and 1/3 patient do not survive to receive second line treatment. So we should start the osimertinib as much as possible in a first line treatment, which is the preferred one. The final overall survival of Flora trial reinforce osimertinib as a standard of care for metastatic lung cancer as a first-line treatment. Thank you for your such an experience sharing discussion with this metastatic lung cancer patient. I thank all the expertise, the consultant, those who spoke about the three topics, as well as delegates, those who are listening patiently. Now I hand over the mic to Nishan for vote of thanks. Good night to all of you, and thank you very much for your kind attention on this scientific program. Dr. Nishant for vote of thanks.
Thank you very much.
Good night.
Thank you everyone for joining and wonderful talks. And thank you audience for joining. Good night. Technical team, please close the meeting.